There you are. Perfect. Okay, I'm going to turn my camera off and just 2 minutes of introduction. Thanks, guys.
We'll give a few minutes. I'm not sure the participant can see us for now, but we can wait for a person to join in.
Yeah, I'd say there haven't been many people joining yet, but we are live now, Adelaide.
Yes, okay. So should I start a few minutes or should we jump in?
I think perhaps we just wait 1 or 2 minutes for the last people to join up, and then we can begin whenever you're ready to do so.
We still wait for 1 minute. I think there's more participants joining, so I guess we can start. Yes. So I'm Adelaide Challier. I'm the Nutrition and Surveillance Advisor for Action Against Hunger. I'm delighted to moderate this session today. Welcome all. So we'll have 2 presentations during this session. The first one on wash and wasting treatment, and the second one on health systems functioning. So I'm going to give you a quick overview of this session. So we'll have those 2 presentations for both 20 minutes, and after we'll spend some time on the question and answer. So we'll try to answer them directly in the chat and take some time at the end for discussing them. So as per other session, if you have questions, it's on the Q&A session on the right. So let's start. So we'll start with the first presentation. So the first presentation was prepared by more than one person. So it's focusing on wash and wasting treatment. It was prepared by Franck Flachenberg, which is the Senior Wash Technical Advisor for CMAM, and he's 21 wash program across the world. He worked in more than 30 countries, mainly in Southeast Asia and West Africa. The presentation was also prepared by Samuel Mazang, who recently joined Action Against Hunger France and is the WASH advisor covering Central Africa, and is the focal point for WASH and nutrition within the organization. Also prepared by Stephanie Stern, that you can see here. She's the Senior Knowledge Management Advisor for Action Against Hunger France. She created the ACF Knowledge Lab unit in 2016. To reinforce the learning culture of the organization. She designs and implements innovative methodology to bridge the gap between scientific evidence and action, and you will see one of our contributions during this session. And finally, myself. So I already quickly introduced myself. I'm Adelaide Challier again, so Nutrition and Surveillance Advisor for Action Against Hunger France. So I mainly work supporting nutrition programming in diverse settings in more than 10 countries. I worked with CMAM also previously, Save the Children, and now with Action Against Hunger for a few years. So I will start sharing my screen. And if you are unable to see, I will invite you to let me know. It should be in full screen mode now. Yes, so I don't hear anything, so I guess it's working. I don't see the chat anymore. So the first presentation is, as I mentioned, focusing on the link between WASH and wasting treatment. So we'll have a quick overview on the WASH nutrition strategy quite quickly, and then we'll jump in to look at the work based on the R4ACT, the Research for Action methodology, who focused on the impact of WASH and acute malnutrition. And we will look closely at 6 recommendations that was made, focusing on ensuring household water treatment quality during sun treatment. So a quick look at the WASH nutrition strategy. So you might recognize the guidebook that you see on this slide. So of course, we know that the two main underlying causes of undernutrition, so namely unsuitable or insufficient food intakes and diseases, are directly or indirectly related to inadequate access to water. The figure on the left illustrates multiple pathways, both direct and indirect, which demonstrate the dependence of nutrition status and the WASH environment. The poor WASH condition facilitate the ingestion of fecal pathogen, which lead to diarrhea, intestinal worms, or environmental enteric dysfunction that you can see in the middle here. Those are the three pathways to undernutrition. This directly related to the body ability to resist and respond to sickness by affecting the absorption of nutrients and decreasing body's immunity. Other water and sanitation related illnesses such as malaria, dengue, yellow fever that you can see on the left side, as well as chronic poisoning with the example of arsenic on the right, are also contributing to the deterioration of the nutrition status of children or within the population. So those are the direct link. And you can see also in this graphic the indirect link between WASH and nutrition status that are illustrated in this graph by the black arrow. So they are more referring to primarily the socio-economical environment, such as access or affordability of WASH services. It should also be taken into consideration, of course. In the red box here, identify the pathway who are directly linked to water quality, and you will understand soon why I'm highlighting this. So this graphic is included in the Action Against Hunger guidebook that you can see on the right. It's a guidebook presenting a WASH nutrition strategy, which is based on 5 pillars that you can see on the right. So we'll now focus on R4ACT, Research for Action. So Research for Action is a participatory methodology to facilitate the understanding and use of scientific evidence with methodology in 5 steps. So the first step is to define a question. What is the question we want to take into consideration, and what do we want to answer? So looking at the R4ACT linking WASH and acute malnutrition, the question that was picked was what is the impact of WASH activity on SAM? And to be able to cover the full spectrum of WASH, 16 programmatic sub-questions were included. So all the 16 programmatic sub-questions can be seen in this table below. So that was the first step. Continuing in this methodology, we went through step 2 and 3, which is state of evidence and analysis. So a review in order to respond to this question. The 2019 R4ACT report that you can see on the right here examined the impact of WASH activity on acute malnutrition through a systematic screening of scientific publication. It highlighted based on 24 selected robust articles. So the main findings from this report and this systematic screening was that first, there is an evidence gap on a crucial need for research to understand the causal links between different WASH activities and the treatment of and prevention of acute malnutrition. We can see here the summary of the evidence in this table, and out of the for 14 out of the 16 WASH activities investigated, evidence as of today is insufficient to assess the nature of their impact, if any, on acute malnutrition. The other findings was that it was difficult to discern the individual impact of specific WASH activity on malnutrition because they are implemented together and are context specific. And finally, one finding was that the provision of household water treatment products during SAM treatment improved recovery outcome. And this was the only moderate evidence of positive impact. And this finding was based on 2 high-quality studies that was implemented in Chad and Pakistan in 2018. So we were at step 3, and now we passed to step 4 and 5, which was focused on how to actually implement, how can we use this evidence? So by the operationalization and implementation. So in response to the findings, the R4Act process with a workshop in November 2019 in France, who gather multiple stakeholders from both WASH sector and nutrition sector, as well as health experts, to produce a programmatic recommendation. So they were really focusing on the evidence and the research uptake from the report. So the most robust and actionable findings found, as I mentioned earlier, was the impact of household water treatment during SAM treatment. So during this workshop, 6 recommendations were made based on this finding. And recommendation to be made, and also what type of advocacy to be made at local level and global level. So we will now have a closer look at these 6 recommendations, and more particularly every time to a specific suggestion of activity. So this is extract from the report from the workshop led in 2019. So for every recommendation, we have a main recommendation on the left here. We have a set of 1 or 2 indicators to allow for monitoring for this recommendation. And we have a suggestion of activities. So the first recommendation is to select the most appropriate household water treatment method in the area covered by SAM treatment. So how could we actually implement this? What type of activity we can put in place? So one activity that we wanted to highlight during this session is the one highlighted in green here. So in case of ICCM plus approach, carry out joint distribution of household water treatment product to accompany SAM treatment. So how to actually implement these activities? So the first step is really to review the existing prevention package as part of ICCM plus, or if the plus is not yet implemented, look at the ICCM approach already in place and look at the activity within this prevention package. So one example we picked is from Mali, where the CHW already promotes the use of water treatment products. So the idea is really to review what is being done and how we can strengthen the prevention package, looking at these activities. And by looking at the 6 recommendations, one suggestion is really to strengthen the coordination between those 2 sectors, of course, and the integration between WASH and nutrition, and also health sector. So how can we work together? We could implement a feasibility analysis to understand if adding such activity is possible, because it really depends on the context. And also we fear we might overload community health workers. So we will need to do this type of feasibility analysis before proposing such activity. Then we could prepare joint training for community health workers to allow them to be able to distribute such water treatment products, and also to be able to supervise the use within the communities to understand if there is an effective use of this product. Another proposition will be to do a joint supply chain to be able to monitor the supply jointly between WASH and nutrition actors. And finally, also during supervision, maybe we could add a WASH expert to come in and join the supervision, including for post-distribution monitoring. The second recommendation is to systematically coordinate the delivery of household water treatment adapted to the context with SAM management. So one activity suggested that we wanted to highlight is to give to caregiver a follow-up stock of water treatment product at discharge. So how to actually do that? It's first to realize at what time you want to do such a provision of products or distribution. So by experience, we see that it's largely done at discharge by providing or distributing a WASH kit, while it's not always implemented at admission, while when we see the evidence found during the screening of evidence, we see that it's important to actually start at admission for the duration of treatment. And of course, if possible, to allow for provision of a follow stock, so meaning that when the child is being discharged from treatment, the caregivers still have a supply to continue doing the treatment of water. So the recommendation on how long this distribution will last will really depend from one context to the other, but we could look at the moment where relapse is the most happening in the context. So we could look, for example, at a 2 months period. And then, of course, doing this provision at a health facility level or nutrition site, it's really an opportunity for a point of contact with caregivers. So we need to think of adding training of or sensitization of caregivers at the health facility level or nutrition site on how to actually use the product that was provided. And you can see on the right an image from different type of water treatment and also water treatment products. Franck, do you want to take over?
Yeah, thanks, Adelaide. Recommendation for 3 is to develop behavior change in area covered by CMAM treatment. So the core idea here is that distribution of wash and FI or equipment should be systematically followed or even preceded by a behavior change campaign that will promote the use of this equipment. And this is particularly important when talking about household water treatment because we know that it's very difficult to convince people to adopt such practices. Chlorination, for instance, gives a very bad taste to the water, so people, are often reluctant to use it. And if I take another example, like the water filters, well, we know it requires regular maintenance, and therefore the compliance is often not very good. So behavior change campaign is vital to raise the demand for using these types of equipment. But now, when we talk about behavior change campaign, we are not referring to the usual hygiene messaging. No, we need to adopt the recommendations of the behavior change expert, international behavior change experts. So let's see 3 key principles of this. So next slide, please. First, 1 or 2 maximum topics per campaign. Too often, our hygiene promotion activities are covering too many topics. And we know what is the result of that. The result of that is the knowledge behavior gap. So we don't want that. So that's why we need to adopt these new principles of actions. A second main principle, hygiene promotion campaign give much better results when their content is based on insights collected at the community level. By insights, I mean, the barriers, the drivers in the specific area of interventions that prevent or favor the adoptions of the promoted behaviors. Third, and maybe the most important one, let's move away from the boring hygiene campaign, such as, you should treat your water because it's good for your health and this type of messaging. It just doesn't work. I mean, it works to raise the knowledge, but it doesn't trigger the desire for adopting the new behavior. So if you want people to pay attention, of course, you need more striking slogans. You need entertaining sessions. You need to make them laugh or trigger a reaction of disgust, whatever emotional reactions that you choose. But what the science of behavior change tells us is that in order for humans to adopt a new behavior, we need to associate some information with a strong emotions. Okay? Voilà. I'm not going to develop more because I'm too talkative, but Adelaide, I might over to you then for the next recommendation. Thanks.
Thank you, Franck. So I'll pass to the next recommendation, the 4th recommendation. So it's to train identified health facility or healthcare facility staff on health center water system management and building caregivers' capacity on correct use of household water treatment products. So one activity to be implemented to assure to follow this recommendation is to include a water treatment, water training component within a nutrition training session and vice versa. So how to actually do that? One first step, really important, is already identify your training. What type of training is already available and implemented? What are the training curriculum available? Once this step is done, you have to understand the key messages that you want to include in each WASH and nutrition training. So of course, here we are focusing on water treatment, but it can be an overall WASH intervention. So once the revision of curriculum can be done, we have to think out how you want to do the training. So one example we are mentioning here could be a cascade training. So not something really an innovation, but we could think of WASH staff within a district level training, nutrition staff at district level. So it could be MOH staff, for example. And later on, this person can train the nutrition staff within the healthcare or nutrition facility or nutrition site. But we don't really want, and it's the same for the recommendation and also the indicator we are proposing, we do not want to propose something in addition. We really have to understand what is being implemented. There are many WASH in healthcare facility initiatives in place. So the idea is also to look at what is actually promoted or implemented where you work. So we have to make the link with existing training and initiative and make sure both sectors work together. So one example we picked here is the WASH Fit, the WASH facility improvement tool that is more and more being used by organizations and also ministry. So the aim of this approach, who was, I believe, developed by UNICEF and WHO, is to create a team within a healthcare facility, a team when you have enough staff or focal points, to be in charge of water quality and to actually monitor the quality. It's not a one-time checklist. It's really to have a process to monitor the quality. And it has a set of tools to be able to do a baseline on the quality, looking not only at water quality, but all the WASH intervention that should happen at healthcare facility. This is linked to my last point on train one focal point. So it's, again, just not to have to do this at one time, but to have someone in charge of assuring the water quality within the healthcare facility. And we know sometimes healthcare facilities are quite small and there are only few persons working there. So one proposition here is to promote the healthcare cleaner to be a hygienist. So the idea is to train this person to be able to take over this new responsibility and maybe have a discussion maybe at district level to make it sustainable. Or for bigger healthcare facility, we could look at who is the IPC infection prevention and control focal point, and if this person has actually this responsibility already within his role. The next recommendation is on data. So ensure information, knowledge, and data sharing between WASH and nutrition sector. So how to actually do that? So we picked a suggestion which is more focused at country level to ensure that WASH and nutrition sector coordination are connected at country level and share data to improve geographic coordination and joint activity. So I no longer show you bullet points because we picked actual example from South Sudan. So it's mentioned an example from WASH cluster, but actually from other cluster too. So it's showing how they identify the priority area within the country. So they actually look at the WASH vulnerability scoring that they had and the type of scoring used by the food security and nutrition. So it was actually the IPC phases. And they did overlap of those two scoring or IPC phase. And they choose a threshold for the WASH sector of threshold 4 and 5. So it was the scoring where persons were the more in need of WASH services. And for food security and nutrition, IPC phase 3 and above. So they did overlap of those two scoring or phase. And this is where they identified the main area. So if we have someone from South Sudan, don't hesitate to comment on this slide in the chat. And I believe it's a way of working also for other clusters like Yemen. The last recommendation is to improve water system in health facility. So before I jump to the activity we wanted to discuss during this session, we can have a quick look at the indicator because we didn't have time for the other. So just to confirm that we are trying not to propose new indicator, here you can recognize maybe the sphere indicator looking at availability of water for inpatient and outpatient facility, as well as the water quality indicator. So the activity we wanted to look at was to ensure water quality is taken into account in health system strengthening programming. And you will understand the link with the next presentation, of course. So how to actually do that? So first we have to understand at country level what is included in the policy from both WASH policy and nutrition policy. So are they actually well integrated or not? So a good way to start is to look at this report here, the recipe for success, which has a mapping of 10 countries. So you can look if the country you are working in or supporting is part of this mapping. And they had an analysis of policy for nutrition and WASH, looking at the level of integration. And I believe one of the findings was actually nutrition policy were more including WASH, but for both WASH and nutrition sector, a big gap was on the feasibility, the implementation, on how do we pass from policy to plan of action plan. And finally, a good way also to do that is to include WASH component within HSS diagnostic. And this is the experience within Action Against Hunger. So it's something Sarah will discuss also on the diagnostic. So it can, adding such a question can lead to prioritization of WASH component in the MOH action plan and budget at district level. So this was my last slide, just a quick note that all the references are in the presentation that I believe you will have access later on. So we put the link from external resource, but they are all on the platform and you can access them. Thank you. So now we'll pass to the next presentation led by Sarah. Sarah will share a screen. Sarah, I will let you introduce yourself. That's okay.
Hello, everybody. Thanks for having me today to talk about health system strengthening. So my name is Sarah Brousse, and I am working at Action Against Hunger France as a health system strengthening advisor for the whole organization. So today I would like to take a couple of minutes to discuss with you why it is relevant to adopt a HSS approach when it comes to wasting in particular and when it comes to nutrition in a more global way. So to follow up on the last topic that was mentioned in the previous presentation, I'm going to bring another perspective to the management of wasting, and I really propose to take a step back to look at wasting and nutrition in general through the lens of health system. And during this short talk, I would like not to look at how nutrition services can be added to health systems, but rather at how working on health system can actually improve your nutrition outcomes. So first, let's see why it is relevant to adopt such a perspective. I think in the last day we've heard a lot that the coverage of therapeutic program for acute malnutrition remains very low, unfortunately, and is estimated to be around 13 to 15% for wasted children. So there are many reasons behind that, but I just want to put forward some of the few reasons that I think are useful for our presentation here today. I think it was on Monday that it was mentioned that no matter how high the results of the cure rates of nutrition program are, if the initial targeted population remain very limited, the overall coverage of your program is actually doomed to remain low. And And indeed, an important proportion of wasting cases are actually outside of the humanitarian so-called context, let's say, where there is no sufficient external partner to provide such nutrition services. So as of today, there is a great proportion of nutrition services that are still delivered by external partner rather than by the Ministry of Health. And since policy makers do not tend to prioritize such services, we observe that in many locations. So I think it's highly necessary in these places to promote health systems that offer essential nutrition services along the continuum of care as an integrated approach rather than as a parallel one. So I think we all agree on the fact that health and nutrition are closely linked one to the other. Health is now a recognized determining factor for undernutrition, since prevention and treatment of major childhood diseases will actually lead to reduce the prevalence of undernutrition, as we know. And I think this point was really emphasized by the Lancet a couple of years ago with this list of proven interventions that were related to pregnant and lactating women and also young children that would considerably reduce undernutrition rates if they were correctly offered in the essential health package of the continuum of care in the health system where we are actually working. Another point I think it's interesting to raise here for our discussion is that we now know, thanks to many studies, what are the main barriers to access nutrition interventions, and some of them are related to barrier to access health services in general. So we can just list a few, such as the distance to the point of care or the high opportunity cost that we observe when a family has to undergo treatment, or also the lack of knowledge on the disease or program. And these points are closely related to health services, as we can see. And it is also closely linked to the quality of the services when they are available, since they are embedded in the contextual situation of the health system. They actually rely on the level of quality of services of the health services in general. So it means that there is quite a need to have a kind of comprehensive approach for health and nutrition rather than sticking to vertical disease-specific one. Comprehensive approach, as I think we can say, are on the way in many places, and there is a good dynamic of integration of nutrition in the health services in many places. So on the one hand, there are places where there is this, let's say, political will for integration, and most of nutrition-specific intervention will then be included in strategies, for instance, or even in the protocol at the point of care. And they will, most of the time, really use the existing delivery mechanism of care to propose this nutrition intervention, meaning that they will use the same staff, for instance, or the same health facility. So this is a good point. But on the other hand, I think it's important for us to have a broader perspective on this issue, and to realize that nutrition services are integrated at the point of care in some places, but the systemic integration of nutrition is still lagging behind. So when I mean systemic integration, I really want to say that the nutrition component is not properly integrated in the 6 building blocks of the health system, as you can see on the slide. And it remains really focused on the service delivery. And several studies showed now that this systemic integration is not happening. And just to give you an example, in sub-Saharan Africa, for instance, funding for nutrition are largely driven by development partners, even for aspects that would be expected to be covered by the government themselves, such as the salary of personnel, for instance. So it can bring a good success of your nutrition indicator on the short run, but ultimately this will definitely hamper the sustainability of the program and the systemic operational integration of the essential nutrition activities. So again, I think having a broader perspective here is important, and I really want to invite you to reflect on the lessons learned we drawn from the vertical program we saw in the last decades. So just for the reminder, the vertical program are those programs that were or are focusing on one single disease, such as HIV or tuberculosis, for instance. So you have specific funding that are available for that, and you can then provide mass prevention campaign or treatment for those specific diseases. So for sure, it's going to boost a lot your outcomes for this specific disease, for acute malnutrition, for instance. But again, I think it's important to see the broader picture here and to acknowledge some of the main shortcomings that was identified with this vertical program, which is that having such approaches is actually fragmented the health system in which you are working and is, on the long run, really weakening them. It means that you are going to shift resources available in the health system to your short-term vertical program. So you're going to boost your outcome there, but it's definitely going to hinder the outcome, the other health outcome of your health system. So even though there's no successful model for integration, because it varies a lot according to the context, the specificity of the health system, there is definitely a need for an integration that addresses the 6 building blocks of the health system, and that is more comprehensive. And this kind of approach will definitely lead to more sustainable and efficient solution, and ultimately improve your nutrition outcomes, but also your non-nutrition outcomes. So comprehensive approach are definitely a good way to go, and to carry out such approaches or vision, health systems are a primary component in the equation to improve the mortality and morbidity of the indicator, be there for health or nutrition. So this health system will be key in improving the coverage, increase the quality of services, assure equitable access to such intervention. So once again, I think the health system are a cornerstone for reaching the universal health coverage and for the improvements of the outcome I just mentioned. So the point I mentioned in my previous slide, and here I think emphasize really the interest of considering approaches that focus on the health system and that take into account specificity of undernutrition or wasting, if you want to be very precise. So this type of approach are called diagonal approach, and they are at the meeting point between vertical and horizontal approach, of course. And they're really aiming for disease-specific results through the improvement of health system in general. And this has proven to have really sustainable improvement in the long run, and also provide tailor-made solution to the context and to be able to address specific components of wasting, for instance, of acute malnutrition, if you want to work on that. So this comprehensive approach, including diagonal approach, are definitely in the same dynamic, let's say, than the universal health coverage that we heard a lot these days. Universal health coverage is a historical international opportunity to move forward, to make great progress in the transformation of the health systems, and also to eventually ensure that nutrition is actually included in an adapted and relevant way to these national health systems. So it means that on the ground today, governments and partners are encouraged to make policy and financial commitments to contribute to equitable health system. That would include nutrition components according to the needs of the population and of the epidemiological profile, etc. And the success of these policies strongly rely on the implementation of such policies and strategy. And the implementation is always strongly related to the level of performance of the health systems. So it means that for the success of the implementation of such policies, we need to have strong and resilient health system in the location where we work. a good phrase that I think we need to remember today after this conference is that no country can actually achieve universal health coverage without investing in essential nutrition actions. But at the same time, the good nutrition for all cannot be achieved without a universal health coverage. So the nutrition community should also take the train of UHC and make sure that we really consider this broader picture in our quest to improve the coverage of nutrition intervention and improve nutrition outcomes. So strengthening health systems and adopting diagonal approaches are definitely a mean to achieve UHC. I want to take the last couple of minutes that I have to illustrate what I'm just saying, which can be a bit theoretical in a way. So I'm going to take the example of a program that we are working on within Action Against Hunger, and which is aiming at strengthening the health system at the district levels. So Action Against Hunger has developed and deployed in field this program that are really aiming at strengthening the planning process of the health districts using an evidence-based approach. So let's say that the vision we are promoting here on health system is really based on what I just listed in my previous slide, and we really put forward the idea of having this systemic overview of the health system to provide more sustainable changes. And we also want to act at the district levels because we think it's very complementary to the national initiatives that are more policy governance oriented, and that partners as Action Against Hunger definitely have a role to play in the support of district in the implementation and the adjustment, let's say, of strategies when it comes to health policies and nutrition policies. So we are really promoting kind of bottom-up approach here to make sure that the voice of the lower level of the health system are heard and are taken into account in the development of the district and regional action plan. So this is performed through a very participatory process that really gather many people of the health system, the key actors from the Ministry of Health at the central level down to the community representative. And to do that, we are acting on two sides. The first one is to adopt this evidence-based approach, which is carried out through an evaluation of the health system. And once we have this evidence, we then use it to identify priorities of actions for the health district, of course, and we define the sets of activities or an action plan that should be implemented by the health authorities to address these first priorities. So I just want to take the example of Cameroon, where we implemented such a program a couple of years ago. So it took place at the really right time for Cameroon, since the country was working on the development of their national health development plan at that point, and they were really on the verge of asking their district and regional level to do the same and develop their own district action plans. So we took this opportunity to support the Ministry of Health at the various levels in this work of developing the regional and district action plans. So we adjusted a lot our program, our HSS program, to make sure that it actually meets the framework of the Ministry of Health on this, to meet their objective, their format, fit their timing, etc. So all this work was actually carried out under the ownership and the leadership, let's say, of the health authorities at the various levels, who are really driving the exercise and giving the great direction that should be taken. So ACF was actually here as an advisory technical body to make sure methodology were ensured, or we suggested adjustment in the method to make sure like the participatory component were in place, for instance, or this kind of thing. So the great success of this experiment was that we managed to, with this evidence-based approach, we managed to build a strategy for the next 5 years for the health district. And they used this to actually finalize their own regional health plan for the region of the extreme north. And it was really good because with all this process, we really managed to generate, let's say, a synergy of actions with all the health actors, nutrition actors of the district and of the region, but under the leadership of the health authorities. So there were really this important synergy of action, and everybody was trying to use at best their resources and expertise to contribute to the synergy and to the, let's say, district health plan that was developed. So I think to conclude on this short introduction on why we should be broadening our perspective on nutrition and on wasting, and try to look more at the bigger picture, I think it's important to keep in mind that health systems are really the backbone of the service that are delivered at the point of care, at the community level, and they really lay the ground for an equitable access to quality health and nutrition services at all levels. So adopting diagonal approaches that strengthen the health system on the long run, but also take into account the specificity of nutrition or wasting services, will definitely allow to contribute to the achievement of the universal health coverage by 2030. So I'm going to stop there. Thank you.
Thank you, Sarah. So we have a couple of minutes. There is only one question. I don't know if you can see it, Sarah. It's for you on HSS. For the moment, we have only one question. So I'll let you read it, but not read it. I will read it. I'll let you some time to look at it. So the question is saying that this person is interested in countries without a strong and resilient health system. For those like Niger, where only 50% of the population are rich, what sort of time frame do you think is needed to develop a health system? What can you do in the meantime to work in a way that will eventually support the development of a strong health system, but address urgent need now?
Thank you. Thank you for this question. I think it's a very let's say it's a question that we have to answer a lot of time based on the context where we are working. And this is definitely something that we had to address in many places. So when we revised our health system strengthening approach, we really wanted to address this issue. And what we were thinking is that we have to think in a very adaptive way, and we have to think in a programming adaptive way, more specifically. So what we are promoting now in this with our HSS approach, and that can be broadly, I think, used, is that we are really suggesting to get adjusted to the need and the situation of the health system where we are working. And we really encourage as much as possible to think of strengthening activities that will improve your health system in its structure itself on the long run, and will really allow to have structural improvement, let's say. But this takes a lot of time, and it's more on a development dynamic, I would say. So what we really encourage to do is be, let's say, agile in your programming, and be able to, at the same time, offer activities that are more related to what we would call support activity, that will allow you to answer the direct need of the population at a certain moment of time, and will allow you maybe to solve the problem of supply. It's what you are dealing with at this moment, to make sure that the continuity of services can be ensured with a sufficient quality. And I think we have to go beyond that even, and take into account the situation where we have crisis or important shocks like it was for with COVID, sorry, where the Ministry of Health is sometimes not able to assume his role because it is too weak or the situation is too challenging. And in this case, I think it's the role of the partners also to substitute to the Ministry of Health for a certain period of time and a certain mandate to make sure that the continuity of care is going on and the specific needs of the population are answered. So to summarize my answer, I think it's important to be agile in our responses and in our way to strengthen the health system, to make sure that we are able sometimes to work on long-term structural solution, but at the same time couple it with more immediate responses and efficient activities. Over.
Thank you, Sarah. So I don't know if you see this, but I will ask you another question because we have another question on HSS. So when integrating HSS and nutrition, what are the 2 or 3 most important don'ts? You have such key messages that you want to pass on? We have another question also for my WASH colleagues. I don't know if someone wants to take over this question from me.
Yeah, the question is around water treatment issue. How can we overcome the fact that pathogen which mainly cause diarrhea can vary by area? Should I answer that, Samuel, or do you want to do it? I'll just go for it then. Okay, so basically where the chlorinations or the different household water treatment pathology are answering most of the, they can be an answer to the main pathogens. There is some question when it comes to virus, but when it comes to bacteria and the usual one that cause diarrhea, actually all these household water treatment methodology are working, whatever the types, the exact types of pathogen is it. So that's the answer. Bye.
Thank you, Franck. So Sarah, we could not hear you. I don't know if you want to answer.
Yeah. So for the question of the don'ts, I think it's important here really to put forward that we are not trying to integrate HSS and nutrition. We are trying to promote the idea that we need to have a strong health system, resilient, effective, etc. That actually include nutrition in its essential package of services where it's relevant. But I think one of the mistakes that shouldn't be done here is really what I mentioned in my slide, to think that if you have nutrition services added to your protocol of care, that's sufficient. Because you really need to think with the broader picture and pay attention to the fact that if you want to have a nutrition service that is working, you need to have a proper university training, you need to have a good supply chain and the funding that are integrated in your government's funding schemes or maybe insurance to make sure that people can actually access it and that you are able to provide quality services. So I would say that it's really important to think of adding nutrition to the essential to the package of care, but making sure that it's actually done on the whole health systems so that you won't have the problem of having it offered at your point of care, but with poor quality or without any supply that are available, etc. So having this comprehensive approach, I think, is definitely important. And also keep in mind that strengthening the health system is something that takes time and that is more on a development rhythm, I would say. So we can definitely initiate quick wins, as we did, for instance, in Cameroon, by helping the governance of the local health system to change this point or this point and make sure it's integrated in their own strategy. But if you want to have institutional changes, it means you also have to be ready for a strong advocacy campaigns or strategies that should be directed to the Ministry of Health, because in the country where we work, most of the time it's quite centralized. And these institutional changes, for instance, on the financing scheme, is going to take a couple of years. So it's important to keep that in mind and to be prepared for a long project, I would say. And again, I think it's important here to realize the importance of the opportunity of universal health coverage, because there are really pledging that are happening. There is an international dynamic that really encourages government to go in that direction. So they will review and revise their policy, their strategy. So it's the time now to encourage them to make these important changes in their health system, make sure we go in direction of equitable health system with quality services, etc. And where it's relevant, to make sure that nutrition is actually on board as well.
Thank you, Sarah. So we have a final question again for you, Sarah, on HSS. So we'll take just a couple of minutes for this last question. So you can see it's actually a two-part question. So ideally, how long it takes to strengthen the health system up to the desired level? What are the major challenges faced on HSS? So I guess when designing HSS programming. Oh.
Okay, thank you. So I think here it's important to make a difference between strengthening the health system and the health system strengthening program of action against hunger, which is only a contribution to this bigger point. Because strengthening the health system is more under the mandate of WHO or this kind of people, and it really takes a lot of time, as I said, since we want to reach institutional changes. For the HSS program of action against hunger, what we observe is that we need maybe a couple of months, up to 6 months max, to work on this evaluation of the health system at the local level and work together with the health authority to develop the action plan or the strategy of intervention. So it's, let's say, about 6 months. And after, we also have to support the implementation of this strategy. And this is, of course, taking a while because the strategy are designed for 5 years, 3 years, etc. So you also need to make sure that you have the project or the financing of the project that are following up these needs and that allow you to support the health authorities and the health district during this period of time. The main challenges we are facing very quickly, I think, today is definitely a shift of priority due to COVID, where it's really difficult to mobilize the health authority on these long-term changes that we want to make on the health systems, since they are all very busy with these, let's say, urgent needs. But I'm really confident that later on, once the acute phase of the crisis will pass, we will see again all the conclusion of this experience saying that we need to have strong health system and resilient health systems, and that attention will be put again in that directions. I think another challenge is really to make sure that we are not, we are matching the needs of the health district or the health region where we are working, and we really contribute to their own objective, to their own needs and plans, and we not come as a solution already set. We should really come and be open to what they need and see how, with our expertise and resources, we can help them to improve the way they want their health system to be working, and making sure that we ensure also principles such as equitable access, quality of services, etc. I think I'll stop here for now.
It was a very comprehensive question, so I guess you can continue, but yeah. We'll have to stop. Thank you everyone for your participation and your great questions. Thank you, Sarah, for your very detailed answers. So just a quick note that we remain available within this platform, so you can contact us if you want. If you have other questions, don't hesitate. And also you have our contact in our presentation. So it's time for the end of the session. I really appreciate it, and I hope you did too. So please, as usual, you can go back to agenda and information to look at the next session. So we'll have a break for 20 minutes and our speed networking if you want. And then we'll join Kate Golden for the session at 2:30 CET. She will discuss the summary of main conference outcome. Thank you, everyone.